Welcome to the RCI GDAS webinar with Dr. Ellen Cotter. The title is Identifying and Responding to Mental Health Issues During Assessment and Care Management. Before we get started, let's cover a few of the conference details. If you have a question during the conference, you can type the question or use the raise the hand feature. All of the questions will be answered at the end of the conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of the webinar. There will be 10 questions about the webinar, and it'll ask you personal questions such as your email address. That will enable me to send out your certificate. If you are not at your own computer, copy down the link that is posted on the last slide of the presentation. Use this link at your own computer to complete the post-test. Certificates will be sent out within a week for those who successfully complete the training. To mute your lines, you can dial *6 on your phone, and to unmute, you can dial *7. We're now ready to begin. Welcome, Dr. Cotter.
Hi, thanks for having me.
You're welcome.
All right. If anybody notices at any time that something horrible has happened, like you can't see the slides or anything like that, please say something about it. I think we've got the system working well. Lisa, who you've just been hearing from, is a pro at doing this, so I think she's got us all set up. But if anything weird happens, just let us know. The order of topics that we're going to talk about today, there's four main things we're going to talk about. I'm going to first provide some general information about mental illness, and this isn't meant to be an exhaustive review of every single type of mental illness out there, but just an overview of some common conditions that are especially likely to affect older adults or that you might be wondering about in older adults. And we'll talk about some characteristics of those conditions. And we'll also talk about some practical issues and community resources that people can use for dealing with consumers and their families in some cases, depending on what people's situations are. So we're going to start with kind of a general overview of mental illness with the general idea. Come on, slide. There we go. No, come back. Sorry. There we go. When I teach, I'm a little bit trigger happy with the advanced slide button, so I might be doing that too. I apologize in advance for that. Just in general, some things to know about when we use a mental illness, what we mean by that. Mental illnesses in general are unhealthy patterns of thinking or behaving. Unhealthy means that they cause people to do things that are unhealthy, such as drink too much or neglect their relationships or things like that. Mental illnesses create problems in what we call normal functioning. Normal is in quotation marks because nobody is ever completely normal, but what we mean by that is mental illnesses prevent people from doing the typical things that we think of people doing, such as having relationships, having a job, going to school, being happy, having hobbies, things like that. To some extent, mental illnesses are context dependent in the sense that there can be cultural definitions of what's considered to be a problem and what isn't. In some cultures, for example, if God talks to you in some cultures, you are considered to be very special and divine, and in other cultures, if God talks to you, you are considered to have a serious problem. Also, mental illnesses may not all cause the same degree of distress. A person may have characteristics or behaviors that bother other people but don't bother themselves at all. Or they may have things that they're unhappy about in their own life but that don't bother other people. So, and to some extent, if things don't bother you and don't impair your functioning and don't bother the people around you, that might not be considered as much of a problem. So that's one thing to keep in mind. Mental illnesses may be acute or chronic, meaning that they might be new, kind of short-term problems, or they might be continuations of existing long-term problems. That's a possibility. And it's also important to realize that when we talk about mental illnesses, people can have more than one. Just like with any other kind of medical problem, people can have more than one type of mental illness. And so in certain people, you may see a combination of symptoms rather than just one very clearly defined set of symptoms. And that can make figuring out what's actually going on a little difficult. One thing to keep in mind, and this is something that you may need to explain to consumers and families as well as keeping in mind yourself, is that a mental illness is a medical illness. Mental illnesses are not caused by being weak or lacking willpower. Mental illnesses aren't things that people can snap out of or get over just like that. They're not things that we blame people for, and they're not things that we should be ashamed of, just like any other type of medical illness. We would not typically look at someone with diabetes, for example, and say, well, if you took better care of yourself, you would not have diabetes, and I don't feel sorry for you at all. We would not typically say that type of thing to a person because that would be considered mean. And so similarly, we wouldn't look at someone with a mental illness and say, well, this is your fault. You should fix it and do something about it, because that's not really how it works. Another reason why we consider mental illnesses to be medical illnesses is that many mental illnesses are associated with chemical changes in the brain. The brain works based on chemical activity, chemicals that naturally occur in our bodies. We're not going to get into a big discussion about that. But that is what seems to be associated with a lot of mental illnesses, such as depression. And that's why medications can sometimes be helpful for people, because they alter our brain chemistry. And that's, again, why we consider, part of why we consider mental illnesses to be medical illnesses, because they have a biological cause. Situations can also cause mental illnesses. For example, you experience a loss or a traumatic event and you develop, depression or anxiety problems as a result of that. That can happen. And for some disorders, such as schizophrenia, there seems to be a genetic link in that certain problems, mental health problems, can run in families in ways that can't be explained simply by being around a person with mental illnesses. Just some mental illness statistics, just so to kind of give everyone a perspective of the scope of the problem that we're dealing with. According to the National Institutes of Mental Health, about 25% of adults in the United States currently have some kind of diagnosable mental health problem. So about a quarter of the population. It's not that rare. And when you look at the number of people who will develop some kind of, or to be diagnosed with some kind of a mental illness at any point during their lives, that number jumps to 45%. So almost half of the United States population at some point in their lives could be diagnosed with a mental illness because they meet the criteria set out. So this is not a minor problem that nobody has to deal with. And I know I'm preaching to the choir here on that, but that is something that you can also tell consumers and families about, so that they don't think that they're alone or that this is a problem nobody else has or things like that. If we look just at older adults, about 22% of older adults meet the criteria to be diagnosed with some kind of a mental illness. And this is similar to the general population. As you can see, 25% versus 22% is pretty similar. But older adults are likely to be diagnosed with different types of problems than young adults in some cases. And we'll talk about a couple of those today, as well as one problem that young adults are more likely to be diagnosed with than older adults. So that's, and we'll get to that in a moment. if we look at some more statistics about mental illness, if my slide comes up. Come up, slide. Nope. Sorry, happened again. There we go. In 2006, which I know is a few years ago, but this still gives you an idea of the scope of the problem. In 2006, mental health care cost $57.5 billion. That's a lot of money, as we all know. And so this is not an insignificant problem. This is one of the 5 most costly medical conditions out there, up there with things like cancer and heart disease. And where this comes in, what we're all kind of here, why we're all kind of here today, is because as our population ages, there will be more need for mental health services in the future. If almost a quarter of older adults can be diagnosed with a mental illness, as the number of older adults increases, the number of people needing mental health services will also increase. So it's going to be very important for mental health professionals and people who work with older adults to be able to recognize and handle these types of situations. Okay, what I want to talk about right now, it says at the top of this slide, it says common threads. What this slide and the next slide kind of deal with is the issue that sometimes diagnosing a mental illness can be done through looking at behaviors and changes. And what's listed on this slide and to some extent the next slide are signs that could indicate several types of mental illnesses. These types of behaviors or feelings, especially if they represent changes or things like that, could indicate some kind of a problem. And you might pick these up from your own observation or in reports from the consumer or the consumer's family. There are lots of things that, lots of ways you could get this information. So people who are or who appear to be or who are reported to be unusually irritable, paranoid, or sad, unusually forgetful, people who are experiencing changes in their sleep and eating and activity level, and in some of these cases that could be more or less than usual. For example, some people cope with stress by overeating, and some people cope with stress by not eating. They're too worked up to eat, and we all can classify ourselves into one of those ones, and I promise not to make you tell me which one you are. But so these changes in sleep and eating and activity level can represent things that are either more than usual or less than usual. Sleeping too much or not enough, eating too much or not enough, that type of thing. Social isolation and substance abuse can also be indicators of a problem, and the substance abuse could be its own problem, or it could be a sign of something else, such as depression. Some people try to cope with depression, and we'll talk more in a moment about what that is, by abusing drugs and alcohol as a way of trying to dull their feelings or cope with the things that go on there. So these types of things here, especially when they're recent, indicate that something is likely to be going on. What exactly is going on, that's not completely clear. But these types of changes suggest that something is happening that needs to be investigated in more detail. Now, one reason why it's important to understand this is because these types of changes, these changes in thinking and behavior, being forgetful, being irritable, sleeping too much, things like that, these types of changes could indicate a lot of different problems. And it's very important to rule out things that are not the proper diagnosis. For example, we would not want to diagnose someone with Alzheimer's disease based on the fact that they don't seem to understand what we're saying to them, when really what's going on is they have a hearing impairment. You know, we wouldn't want to do that. That wouldn't make sense, and it wouldn't be the right diagnosis for the person. We wouldn't want to diagnose someone with an anxiety disorder when they really have an ulcer, or vice versa. We wouldn't want to diagnose someone with an ulcer when they really have an anxiety disorder. So if we notice these types of changes, then physical or sensory problems should be ruled out, because some of these things that were discussed on the previous slide could be symptoms of either physical problems or mental illnesses. For example, chronic pain and digestive problems could be a sign of mental illnesses, but they could also be a sign of something else, such as problems with the gallbladder or an ulcer or something like that. So just because you notice those types of things, you can tell that something weird is happening, but that doesn't necessarily mean that the person has a mental illness. It means that something's going on that has to be addressed in more detail, and it could turn out to be a mental illness, but it could also turn out to be a health problem, a physical health problem. Now, if you suspect, whether or not you suspect mental health issues, it's always appropriate to get, or it's always necessary to get the appropriate diagnosis so you can get the proper treatment. Sometimes we don't diagnose problems when we should. This is called underdiagnosis. We may consider a person's symptoms to be either a normal part of aging or a normal reaction to loss. Of course you're sad, you just lost your spouse. Of course it's normal for you to feel sad. Well, the person might have depression that's beyond the normal kind of understandable grief reaction. Oh, it's normal to be a little forgetful as you get older. Well, it is, but we don't want to overlook serious memory problems that could indicate Alzheimer's disease or another type of dementia. We could also go in the other direction and diagnose a mental illness when we shouldn't. That's called overdiagnosis. And if we diagnose a mental illness when a physical problem is the cause of the symptoms, that's no good either. And either way, if we fail to diagnose the proper problem, and this is true in physical illnesses as well as mental illnesses, improper diagnosis and treatment can prevent proper treatment and worsen problems. Just like with physical health problems, many mental health problems do not fix themselves. And so if we don't get the person proper treatment, if we don't diagnose it correctly, we can't get the person proper treatment, and therefore their problems are just likely to get worse. So we don't want that to happen. Okay. Right now what we're going to do is go through some common mental health problems and talk about some of the main defining features of those. Again, we've got some common threads that might be appearing across several different problems, but this is a little bit more specific to give some information about the types of things, or some specific types of mental health problems. And the first type of problem I want to talk about is a category of problems we call anxiety disorders. Anxiety disorders all involve, there are several different types, but they all involve the same thing, which is what we call the inappropriate experience of fear. And by inappropriate, we mean that the fear is unnecessary or excessive. And let me give you an example, and I'm not making this up. When I was in college, I had a roommate who was so afraid of spiders that she was actually afraid of Spider-Man, okay, the superhero, the web-slinging, superhero. This is, being afraid of spiders is not unusual. That makes sense. And in fact, being afraid of things like spiders and snakes helps keep us from getting into trouble, because then we're not all like, oh, what's this? And then we pick it up and get bitten and bad things happen. But being afraid of Spider-Man is not necessary. He is a fictional character. It is not necessary to be afraid of a fictional character. Also, if it's normal to, again, be afraid of spiders, but if, for example, every morning you have to spend an hour dusting out all of your shoes because you're afraid that there might be a spider in your shoes, that's excessive. And hopefully I haven't inspired anyone to dust out their shoes tomorrow morning because you're worried about a spider now. But you can understand how that's a little bit excessive. It's okay when you see a spider to say, eek, I'm going to stay away from that. But if you're afraid of cartoon spiders or or if you're spending a long period of time trying to rid your house of spiders and it's distracting you from other things you could be doing, like going to work, then we call that excessive. I kind of segued unintentionally into a discussion of phobias. Being afraid of spiders would be an example of having a phobia. Phobias are intense fears of specific things, and there's lots of different types. Spiders, snakes, public speaking is a big one, water, lots of things like that. And people who have these types of phobias might go to extreme measures to try to avoid these things in their lives. I've had students drop classes before to avoid having to give a presentation in them, or they've taken an F on something because they refused to stand up and give a presentation in class because they were so afraid of public speaking. Another type of anxiety disorder is what's called post-traumatic stress disorder. And this is what happens when a person has some kind of traumatic experience, such as living through a natural disaster or being the victim of a violent crime, and has a long-term stress response to that. The long-term stress response will typically involve things like nightmares and constantly reliving the experience. Things can trigger kind of a flashback sort of experience where you hear a particular song on the radio and it reminds you of the music that was playing, when people broke into your house and assaulted you, or something like that. And so that's obviously a problematic thing too. One group of people who is especially likely to experience post-traumatic stress disorder is veterans, and also people who've worked in law enforcement, firefighters, things like that, because they encounter a lot of really awful things during the course of their day. And they tend to, in situations that are reminiscent of their traumatic experience, they tend to be kind of jumpy and not able to cope with stress terribly well. Another type of anxiety disorder is what's called obsessive-compulsive disorder, or OCD. Obsessions are repeated thoughts, and such as the idea that everybody is going to die, and compulsions are behaviors that people do to get rid of the obsessions. The compulsions do not always make sense. People may believe, for example, that everyone in my family will die unless I turn the lights on and off 3 times upon entering a room. That may not make a lot of sense, but it doesn't have to. If the person thinks that this is a possibility, then that will happen. And they could spend hours doing this. Washing your hands repeatedly to the point where you can't leave the house because you're spending so much time washing your hands, or you've damaged the skin on your hands by washing them so much because you're so afraid of germs and you can't stop thinking about the germs. That kind of counts in there too. The difference between obsessive-compulsive disorder and just kind of normal pickiness, I like all my shirts to be facing the same way in the closet, but I don't spend hours and hours going through them to make sure that it's that way. I just kind of put them in there that way, and then I don't worry about it anymore. So that's kind of what the difference is with that. I have hoarding on there with a question mark. Hoarding has gotten a lot of attention lately because there's some TV shows related to it. And the American Psychiatric Association is considering right now whether or not to include hoarding as an example of an anxiety disorder. It does seem to have some connections to obsessive-compulsive disorder in that that the compulsive behavior would be the hoarding, and the obsessive behavior would be kind of worries that you might need this or you will somehow be incomplete without it, or something like that. A lot of times when you listen to people on these hoarding shows talk about why they're hoarding, they're doing it because they're trying to overcome some kind of trauma or compensate for a loss, or because they're scared that they might need this someday or something like that. And it's very possible that hoarding will be considered either a disorder of its own or a subtype of obsessive compulsive disorder the next time our definitions of these disorders are updated. Some people have panic attacks, which are exactly what they sound like, and they can come on without warning and can cause people to be reluctant to leave their house because they're afraid that they'll have a panic attack in public or something like that. And some people may also have what's called generalized anxiety disorder, which is sort of a constant worrying, frequently about things that you have no control over, frequently in ways that keep you up at night, stuff like that. And we all know people who are worriers, but they can frequently put things aside and perhaps recognize, okay, there's no need for me to worry about this. There's nothing I can do about it, so I'm going to stop worrying about it. But someone with generalized anxiety disorder would have trouble doing that. So those are anxiety disorders. Lots of fun. Moving on to a second category of problems that we think about is mood disorders. When we say that someone has a mood disorder, we mean that that person has problems controlling his or her emotional state. We all have different moods that we go through. Sometimes we're happier than others and things like that. But to some extent, we feel like we can kind of control that. People with mood disorders do not always feel that way. Probably the mood disorder everyone's most familiar with is depression. Some signs of depression include, but not everyone experiences all of these. That's important to know. Sad mood or crying spells, being irritable, changes in sleeping or appetite, and again, those can go in either direction, either lots or not enough. Loss of interest in activities, particularly things that used to be enjoyable for the person, like socializing or hobbies. Feelings of hopelessness, the idea that life is crummy and will never get any better, and also forgetfulness. And this idea that depression can be associated with forgetfulness in some people will come back to us later on, because it's important to distinguish forgetfulness that might be caused by depression from normal aging-related forgetfulness, as well as forgetfulness that could be caused by a dementia-type illness such as Alzheimer's disease. Now, not everybody shows all of these signs of depression. Not everyone will show them to the same degree. Some people are much better at compensating for them than others. They might be able to go about their daily activities just fine for the most part, and other people will be very significantly impaired by these. So there's a degree to which these things might happen. Another type of mood disorder is what's called bipolar disorder, which used to be called manic depression. People with bipolar disorder have cycles of depression and something called mania, which I'll explain in just a second. And they may have periods of what we would think of as normal mood in between, where it doesn't seem to be one extreme or the other. People who are in a manic episode, and mania does not usually occur by itself. This is important to understand. Usually if someone has these symptoms of mania that I'm about to talk about, usually it's either because they have bipolar disorder and they're just in a manic phase, or they could be under the influence of some kind of drug, such as methamphetamine or something like that. Typically we don't see mania all by itself unless it's caused by some kind of a drug problem. But people who are having a manic episode are people who have what we call unusually high energy. They are impulsive, aggressive, irritable. They might be picking fights with people. They might call you up and say, hey, let's go to Las Vegas for the weekend. Let's leave right now. Don't pack anything. We'll just buy all our stuff when we get there. Let's go. Come on, right now. They might have racing thoughts or speech. You can't keep up with them. They're jumping from one topic to the next, and you can't follow what they're saying. They might go for days with very little sleep or food, which will actually make the problem worse. And they may also have what we call euphoria, which is sort of this unrealistic happiness. They just think everything is great and they're on top of the world and they're absolutely invincible. They can do anything. And they could have very grandiose ideas like, we're going to go to Las Vegas and we're going to win huge piles of money and we're going to quit our jobs. And I quit my job already because I know we're going to win all this money in Las Vegas, so that's what we're going to do. That type of thinking would be symptomatic of a manic episode. If that were happening, especially, again, if it represented a change from this person's normal behavior. So depression and mania are kind of, in bipolar disorder, are alternating to the point where someone will go through days or possibly even weeks of depression, and then it kind of swings up into mania, maybe with some normal interlude, and then it'll come back down again. So we'll see this big fluctuation and stuff. One thing that we don't often talk about, come on, sorry. Oh, no, come back here. There we go. Sorry about that. The one thing we need to address, because this is relevant for people who work with older adults, are some of the risk factors for depression. There's an interesting relationship between gender and age with depression. Up until the age of 80, more women than men get diagnosed with depression. Whether or not that represents the rates of people who actually have depression but just are not getting help for it, that's another issue. But before the age of 80, more women than men get diagnosed with depression. But after the age of 80, more men than women tend to get diagnosed with depression, which is very interesting. Some psychologists believe that it has to do with the idea that that men who lose their spouses can become kind of socially isolated and might be more at risk for depression because they lose social contacts more than the wives tend to. And that hasn't been conclusively proven, but that's one possibility. But other things that might predispose people for developing depression are physical illnesses and use of medication. You know, having a physical illness is lousy, makes you unhappy, and of course as we get older we're more prone to developing certain types of health problems and more likely to use medication, so that can be problematic. Stressful life events such as loss of a spouse, loss of independence, loss of health status, and also caregiver burden can be related to depression as well. So people who are caregivers may find themselves at risk for depression as well. Social isolation and substance abuse are also risk factors for depression, and those things can also be outcomes of depression themselves. So social isolation could be a cause of depression, but it could also be an outcome of depression in that we feel lousy, so we isolate ourselves from other people. And the same is true for substance abuse. So if we know that things are going on in our clients' lives, like caregiver burden or social isolation is going on, or a recent diagnosis of a physical illness, it might be useful to consider those things as possible risk factors and be sensitive to the idea of developing depression there. I've talked about substance abuse a little bit, and let's talk about that for just a second. About a third of older adults meet the criteria to be diagnosed with some kind of substance abuse problem, usually alcohol. Although prescription drug problems are also becoming an issue for a lot of older adults. Substance abuse problems are diagnosed more often in older men than older women, which doesn't mean that older women don't have these types of problems, but they don't get diagnosed with them as much. We really worry about substance abuse problems in older adults because they're especially dangerous with coexisting physical disorders or medications that people may take for various conditions. if you are taking medication to control your blood pressure, for example, that could make you lightheaded. And if you combine alcohol or some other type of drug on top of that, that can create a dangerous situation for you. It can increase your risk of accidents and falls. As we get older, our balance and coordination and reaction time aren't as good as they were when we were young anyway. So when you add some kind of substance abuse or something like that on top of it, that can exacerbate those problems. And again, as I kind of keep saying, substance abuse can be either the cause of other problems or the result of other problems. People may develop depression as a result of a drinking problem because alcohol is a depressant. It works on the body to kind of shut down a lot of activities that we do. But it can also be the result of a problem in that we drink or use drugs to cope with things that are going on in our lives. So it's important to realize that it could go either way, and it may not be easy to figure out which came first in this case. It could be a chicken and egg problem. But the important thing is that in some ways it doesn't matter if someone's having a problem like that. It doesn't matter, at least initially, what's causing it as long as the person gets help. We can sort that out later. We do need to talk about suicide a little bit. Suicide is associated with depression and substance abuse. And one thing that's very important to know about suicide is that older adults are more likely than young adults to die from suicide. One reason is because older adults tend to be in poorer health and they're less likely to survive a suicide attempt. They also may choose a more lethal method than younger people do. Especially older men tend to die from gunshot wounds a lot, and those tend to be pretty lethal as compared to some other things like overdoses. Also, and I didn't put this on the slide, also because many older adults live alone, they're more likely to have a successful suicide attempt because they don't have someone around all the time to make sure that they're doing okay. They could harm themselves and go for a while before anyone realizes what's going on. In 2004, and this is again statistics from I believe the National Institutes of Mental Health, and I know this is a little old, but it gives you again an idea of the scope of the problem. In 2004, 16% of all suicide deaths in the United States were people over the age of 65. So this is not a problem that only young people encounter. In terms of risk factors for suicide, more older men than women commit suicide because they tend to use more lethal methods. Women actually attempt suicide more frequently, but they tend to be unsuccessful at it, which is kind of a weird use of the word successful, but you know what we mean there. Older European American or Caucasian men tend to have the highest suicide rate. This does not mean that people of other ethnic groups or women do not have these types of problems, but older European American or Caucasian men are the ones who are at the biggest risk for suicide. They have the highest suicide rate. This might seem strange, but another risk factor for suicide is improving depression. And this sounds really weird because we would think if your depression's improving, you must be getting better, so you would be less likely to commit suicide. But what happens is this: people who are really severely depressed, they don't have much energy, they don't really have the ability to do a lot of planning, they're just sitting around being miserable, and they're not really thinking about doing anything else except being miserable. But as your depression improves, what can happen for people is that they start feeling a little bit better and they have a little more energy, but they might still feel like their life is hopeless and things are never going to get any better. And this is dangerous because now they have that, again, that continuing feeling that things are never going to get better, but they also now have more energy and more ability to plan. This is really important to understand because we might assume that after someone starts getting treated for depression, their suicide risk would go down. but it doesn't. It can actually go up. And this is true whether the treatment they're getting is medication or therapy. They might start feeling a little bit better, but they're not so much better yet that they're really starting to feel like life has meaning and purpose and hope in it. So just knowing that someone has started treatment for depression does not mean that they are out of the woods on this. And if anything, you might need to keep an even closer eye on them for a little while, just to make sure they're not kind of falling in that kind of gap there. One interesting thing that's been noted for older adults is that older adults who are involved in religious activities are less likely to commit suicide than older adults who are not involved in religious activities. Whether this has to do with a kind of a spiritual component or a social interaction type of component, that's not really clear. But for older adults who appear to have depression, who are neglecting perhaps their religious activities, it might be possible for them to resume involvement in religious activities, even on a very small scale, as a way of trying to address some of their mental health problems without it being kind of a therapy type of setting. And we'll talk again a little bit later about how religious organizations can possibly be useful for helping people deal with mental health issues. One more thing about suicide, and then we'll talk about something else, I promise. When we talk about how to know if someone is suicidal, there are several things we can look for. Statements such as, "I have nothing to live for," or "you'd be better off without me," are usually things you need to take seriously. Behaviors such as giving away belongings, although some older adults do this anyway just because they know that they don't have much time left on earth. They're not suicidal. They're just thinking, well, you've always enjoyed this pin and I don't wear it anymore, so you have it. Giving away belongings can be a danger sign, but it could be a very normal behavior too. It's also important to realize that, as scary as this sounds, some people may not do these things. Some people who are suicidal may not give any really obvious indicators that they are planning to do this. And sometimes it comes out of the blue, and that's really scary, but that is how it is. Anyone who appears suicidal needs immediate help, which you can get from a couple of different sources. You can call 911, you can take the person to the emergency room, but if you are dealing with someone who is actively suicidal, you should not leave them unsupervised, even for brief periods of time, and also limit access to things like weapons, medication, and also vehicles. We would probably, if we were dealing with someone suicidal, we would probably know not to let them around the knives, but we might not think to take the car keys away. But cars can be used to get away to a place where you can carry out a suicide plan, and they can also be used as a means of suicide themselves by people who deliberately cause traffic accidents or things like that. So those are some immediate issues to deal with. And the question sometimes comes up: is it possible that people are saying or doing things just to get attention? Yes, but if they're saying or doing these things just to get attention, that itself is a problem. So behaviors and statements like what we're talking about here really need to be taken seriously. You would rather overreact and risk looking foolish and have the person mad at you than not react enough and risk the person dying. And that's how it goes. Okay, moving on. I'm not sure this topic's going to be any more cheerful as we keep going, but here's what we've got. Another type of psychological disorder. We've talked about mood disorders, anxiety disorders, substance abuse. Another type of disorder is something called schizophrenia. Schizophrenia is a disturbance of three main things: of perception, thought, and emotion. People, when we talk about perception, people with schizophrenia can have hallucinations, which are false sensory experiences. They may hear voices or see things that nobody else sees. They also are likely to have delusions, which are false beliefs. This is the disturbance of thought. They may believe, for example, that someone is spying on them, or that their toaster is really like a computer with a camera inside that is taking notes on their activities, things like that. And people with schizophrenia may also have inappropriate emotions. They may laugh at things that nobody else laughs at, or in some cases not react to things that would cause other people to react. That usually doesn't occur all by itself. Usually you'll have the hallucinations and delusions to go along with that, but that can happen. Now, here's why this is very relevant for all of us here. The most people will experience, if they have schizophrenia, most people will have the onset of these symptoms before the age of 40. If people are older than 40 and they are developing these types of symptoms, the hallucinations, the delusions, if they are developing them for the first time in their older adult years, it is probably not schizophrenia. It is probably something else. The something else could be substance abuse problem. It could be a weird combination of medicines that makes you go all goofy. It could be a brain tumor. It could be something else. But the thing that's really important to understand is that schizophrenia almost never occurs for the first time in older adults. So if you have someone who's having hallucinations, or who all of a sudden believes that government agents are hiding in the bushes and spying on them, if they've never had these types of problems before, it is probably not schizophrenia. It is something else, and it should not be diagnosed that way. Now, what some people will develop in older adult, which is separate from schizophrenia, is they could possibly develop paranoid disorders, where they start to be very suspicious and mistrustful of other people. Usually when older adults develop paranoid disorders, it's usually the result of some kind of sensory or cognitive impairment. For example, you can't hear very well, so you start to believe that other people are talking about you behind your back. Or you're having memory problems and you can't find things, and you start to believe that other people are hiding them from you, that type of thing. And so paranoid disorders in older adulthood are often things that have other causes, such as, again, a sensory or cognitive impairment. And they could be used, people may develop paranoid beliefs as a way of trying to defend against social isolation or feelings of decline or failure. Rather than admit to yourself, for example, that your hearing is going or that your memory is going, it might be easier to allow yourself to believe that other people are out to get you, because then the problem isn't with you, it's with other people. So that could happen. But the bad thing about paranoid disorders is that it can alienate a person's support system, and we don't want social isolation for older adults. But being around people who are paranoid, who are always accusing you of doing stuff, can be really exhausting. And so when people start to become very suspicious and mistrustful of others, we need to look at the possible causes, and we need to intervene so that the social networks for the person aren't messed up too much. Okay. Another type of problem that we sometimes hear about, people being delirious or having delirium, and we'll just talk for a moment about what that is. Delirium refers to acute brain dysfunction with sudden onset. Acute in this case means sudden or short term. Okay? So this is where someone's brain all of a sudden does not work properly. Now, usually there's a very specific reason for it, such as the person has just come out of surgery, or the person has some kind of infection. In older adults, infections can sometimes, like a bladder infection even, can represent themselves as kind of delirious behavior. People with delirium will be very confused. They'll have very disorganized thinking. They can't really follow a conversation, and they can't really have a coherent one themselves. Their speech is likely to be incoherent, and they're also likely to go kind of in and out of consciousness, where they kind of zone out on you, and then they might be back, and then they kind of space out on you again. Now, again, this is something that's likely to happen very suddenly, and it's going to usually be something that can be linked pretty easily to something specific that's happened, such as surgery or a weird reaction to some medication or something like that. And the good news about delirium is that it's almost always a short-term problem. And once you identify the cause, you treat the fever, the anesthesia wears off, you straighten out the medications. Once you can identify the cause, you can treat it successfully, and it's usually not a problem anymore. This is in contrast to what we call dementia. When we talk about someone having dementia, what we mean is that this person has a progressive cognitive impairment, meaning that the progressive part means that it's going to get worse over time. Unlike delirium, dementia usually has a gradual onset. Delirium has a sudden onset. Dementia usually has a gradual onset. And so it will develop over time. You are likely to see changes in things like memory, judgment, personality, and behavior. People with dementia will have trouble remembering things. They'll have trouble making good decisions, like whether or not to trust people. They may undergo personality changes, such as being very irritable. And they may have behavior problems, such as being aggressive or wandering away from home or asking the same question over and over, things like that. Dementia can have a lot of different causes. The most common cause of dementia is Alzheimer's disease, but people can also have dementia as a result of a stroke or Parkinson's disease or a lot of other conditions. If someone has dementia as the result of a stroke, the onset is likely to be pretty sudden, because strokes are pretty sudden events. But most of the time, dementia will develop gradually. And one thing that comes up that we worry about is, how do we know if something is dementia or normal aging? That's always a good question. As we age, we have certain types of memory problems that are normal, particularly short-term memory problems, such as names of new people, or where you've put things, where you've parked your car, where you've put your keys, did I remember to turn off the stove, stuff like that. But the memory problems that go along with normal aging don't affect independence. They might cause you to have to get out of bed in the middle of the night and go check and see if you did turn off the oven. But you can still take care of your own business just fine. With dementia, you're likely to have lots of short-term memory problems. And not only will you have problems like having the same conversation repeatedly, you will also have no memory that you've done that. It's very normal for people to ask someone a question and then realize, wait a minute, I asked you that already, I'm sorry. But someone with dementia will ask the same question repeatedly with perhaps very little awareness that they've asked the question before. People with dementia will also have long-term memory problems, such as forgetting where they live or forgetting the names of family members or things like that. And with dementia, this will affect the person's independence, because not being able to remember where you live or the names of your family members will eventually turn into things like not being able to remember how to dress yourself or how to feed yourself or things like that. So those are things that can kind of help us differentiate between dementia and normal aging. Another important distinction to make, and I mentioned this earlier, is the distinction between depression and dementia, because they can have some very similar symptoms. Depression and dementia are both likely to involve forgetfulness, not wanting to socialize, loss of interest in activities, and neglecting hygiene. But the underlying cause of these problems will be different. Someone who's depressed and doesn't want to socialize is just too miserable to want to associate with other people. They're sad, they don't think it's going to be fun, other people get on their nerves, stuff like that. Someone with dementia who doesn't want to socialize is that way because interacting with other people is stressful due to memory problems. They can't remember the name of the person they're talking to. They can't follow conversations, and they find that stressful, so they don't want to do that. And so, again, it's very important to differentiate these things. A lot of times in older adults, when we see someone with these types of symptoms of forgetfulness and the loss of interest in activities and things like that, we are very quick to assume that it's dementia or some other type of memory problem, but it could actually be depression. And so, again, in the name of getting good diagnosis and treatment, it's very important to make sure you differentiate those two things. Okay, let's talk for a moment about stress, and then we'll talk a little bit about some information, some things for getting information, and things like that. Stress itself is not a mental illness, but it's related to mental health because stress can worsen mental health problems, and we all probably knew that, but I'll spell it out anyway. Stress can also create new problems, such as substance abuse or lack of social support. When I'm stressed, I'm really irritable, and I'm not good to be around, and nobody wants to be around me. So if I'm really grouchy and irritable when I'm under stress, I'm likely to alienate people, and then I don't have any social support. So one thing to do when you're interacting with clients or family members is, if you're trying to decide whether or not there's a mental health issue involved, one thing to ask about would be sources of stress, particularly recent changes or losses. And even changes that are fundamentally good can be viewed as a source of stress. The birth of a grandchild, for example, could be stressful if you're suddenly having to take on some caregiving duties for that grandchild, or if the grandchild lives far away and you're not able to travel to go visit the grandchild. That could be a stressful situation. So changes and losses, and even good changes, are things to ask about because they could be things that are contributing in some ways to mental health problems. Okay. So that's a pretty good catalog of some problems that people might have. What we need to talk about now are some ways to get information and assistance. One thing that can come up when you are trying to get information about possible mental health problems is that you might need to talk to not just the client or the consumer, but also family members, spouse, caregivers, adult children, possibly even friends or neighbors, but people in the person's life. And that might not be easy to do, especially if this would require talking to people who are not in the home. Some things to ask about, either because they can be indicative of health problems or because they could be associated with risk of developing mental health problems, are things like physical health problems. As we already talked about, physical health problems can be associated with developing depression, and they could also be a source of stress or a loss. Enjoyment of food or activities, socialization. Sometimes we can learn about possible mental health problems by talking to the person about what other people say about them. How do other people think you're doing? You say you're doing okay and that you don't have any memory problems. Do other people tell you that they think you have memory problems, or do other people tell you that they think you have a drinking problem? Sometimes people may be aware that other people believe they have a problem or aren't worried about something, but they might not care a whole lot themselves. So sometimes finding out other people's opinions on the situation could be useful. Another useful way to get information is to ask people if they're happy with how things are going in their life. Are you happy with what you're doing, with what you're able to do, with how things are going? Is there anything that you would like to change? older adults, one way to get information about older adults, or one thing to ask about, is to ask older adults if they're having trouble doing things or being independent. And if you're talking to family members or caregivers, an important thing to ask about could be safety issues. Are you concerned that your mom or your husband or whatever is safe, or doing things that are dangerous, or is at risk for, like, getting into a car accident or wandering away from home or stuff like that. And this one helpful thing about doing this is that these types of things can be asked about under sort of the general assumption that, I'm asking these questions because I care about you. I am not asking these questions because I think you have a problem. I just want to know how you're doing. You can ask about all of these things without necessarily bringing up the idea that you think the person might have a mental health problem. And so therefore it can be non-threatening to bring up these types of things, especially if you frame it with the idea of, I want you to be happy, I want you to be independent, I want you to be safe. Let's figure out how well you're doing on that so we can make you happier or safer or more independent if that's what you want, if that's not working out. Another way to get information apart from just talking to people is by observing behavior. This is not always easy to do, but this is something that will happen. I see the chat message at the bottom of the screen. I'm sorry for running over time. This is unfortunately what happens. When we observe behavior, what we would want to look for is changes in things like appearance, weight, hygiene, stuff like that, because those could indicate, again, either a mental health or a physical health problem. Observing the home environment could possibly be useful. Are things clean? Is it tidy? Does it look like the person is kind of maintaining what we think of as being kind of typical standards of housekeeping? If possible, observe functioning. How does the person interact with other people? How does the person, do tasks? Those things may not always be easy to do, and that can be tricky. But if you can observe behavior, that can be very useful. Another type of behavior might be medication related. One way to go about this would be doing what's called a brown bag medication review. That's where you ask the person to just empty out the medicine cabinet. Put all your medicines, vitamins, herbal supplements, everything in a bag and bring it in. Because then you don't have to worry about the person remembering what they're taking and when they're taking it and what the dosage is and things like that. And then you or another professional can look at the medications and say, okay, they're taking these combinations of things, and that could explain what's going on here, or why are they taking this medication? This does not make sense. So that's something else to observe. When we talk about getting information, we might need to, especially from older adults, we might need to focus more on feelings or physical symptoms, more on feelings than on physical symptoms. Part of the reason for this is because as we get older, it's not unusual for people to sleep less than usual as adults, or to have decreases in appetite as they're older, or to have more aches and pains as they get older. And so a lot of measures of depression out there that ask about those types of symptoms may incorrectly diagnose people with depression because they have these normal aging-related health changes, as opposed to simply being depressed. But focusing more on feelings. Are you happy? Are you doing the things that you want to do? Do you feel needed or loved or things like that? Can be a good way to get information. It's also important to know that some people may not realize that they have a problem. In some disorders, such as bipolar disorder or schizophrenia, lack of awareness is very common. And we can see this in other things too, like substance abuse and dementia. People may not realize they have a problem. They don't realize something's wrong, and they may think other people are the ones with the problem. And so some people may get treated for a while and then improve, and then they feel great, so they stop treatment, and then they relapse. And so for some people, treatment for mental health issues can actually be sort of a cycle of getting better and stop treatment and getting worse and all that stuff. Sort of like people who take the antibiotics until they feel better, and then they stop taking them even though they still have some left. That doesn't really work very well for treatment of bacterial infections, and it doesn't work terribly well for this either. Getting people to realize they have a problem or receive treatment can be very difficult because there is a general stigma or negative view in our society of mental illness. And people may be very resistant to the idea that they have a mental illness or resistant to the idea of getting treatment. And the resistance may come from the family or from the consumers themselves. It can come from both places. In the rural South in particular, resistance to treatment is especially likely to be the case for non-white elders who may have had many discriminatory experiences within the medical system and may have grown up with very negative ideas about what's going to happen to you if you go for any kind of mental health treatment. So one way to kind of get around that is that some people may be willing to talk to a medical doctor or a pastor as opposed to a mental health professional or counselor or whatever. So that's something to kind of keep in mind, is that some people may be very resistant to going to a therapist but think nothing of talking to their pastor. That'd be great. When you bring up the idea of mental illness and treatment, you have to use very non-threatening terminology. Again, discussing things in terms of mental health problems, discussing things in terms of medical problems can be very useful. You may want to, if people appear to be having anxiety issues, sometimes talking about doing things to help your nerves can be helpful because then, again, that makes it sound like a medical problem that we don't have as much resistance for. When we talk about maintaining independence and safety, maintaining independence can be a really big motivating factor for older adults because older adults are frequently very, very determined to be independent for as long as they possibly can. And so if you're talking about diagnosis and treatment as a way to maintain their independence, this will help you stay in your home longer if we can get this figured out. Then that might be a very motivating factor. If you're dealing with family members, the issue of safety is likely to be a big motivating factor. This is something that if your mom starts taking this medication or goes to a counselor and talks about her problems, you might be able to feel better and know that she's safer. So stressing the idea of independence and safety can be very useful for people. Helping or expressing to people the idea that treating mental health problems can help them be there for their loved ones, or to help you take care of your needs, can also be useful for some folks. Treatment for mental illness can come from several different sources. People can get counseling or psychotherapy from, again, ministers, social workers, all sorts of folks. Support groups, medication can also be helpful, although if medication is used, the person's medical doctor should be involved to check for medication interactions and problems. Simple stress management and coping skills can also, even just relaxation types of things can be useful for some people depending on what the nature of their problem is. And when we talk about treatment for mental illness, there is no one-size-fits-all approach for that. Different people need different things depending on what problems they have or how severe their problems are. And some people may need a combination of treatments, such as medication and going to a support group or something like that. In terms of community resources, people sometimes overlook medical doctors as being a source of information and support for mental health problems, but they can be very useful. The family doctor, a psychiatrist who is a medical doctor who specializes in the treatment of mental illnesses, a neurologist who is a doctor who specifies in treatment of nervous system problems and brain problems can also be helpful, particularly if the person appears to have some kind of dementia like Alzheimer's disease. A neurologist is likely to be very helpful. Churches, Veterans Administration hospitals, if the person that you're dealing with is eligible for VA benefits. And one thing that's starting to change in the VA health system is there's starting to be a lot more awareness of mental health issues in veterans. And so the treatment that veterans are receiving for mental health issues is really starting to improve over where it has been in some cases in the past. Of course, private psychologists, counselors, or social workers can be useful, and also local mental health or social services agencies can also be useful. One thing I didn't mention here is that support groups, information about support groups can frequently be found in local newspapers in the community events section. And so that's another possible resource. Support groups can help provide valuable information, practical information about coping with a particular problem, as well as give you the feeling that you're not alone, that there are other people out there who understand, who have similar experiences. So checking in the newspaper for support group meetings might also be useful for folks. Again, I'm preaching to the choir here on a lot of this, but state aging services agencies or mental health, or sometimes they're called behavioral health services agencies, could be useful. Some internet resources which might be more useful for you than for consumers and families in terms of getting information about mental health problems and possible sources of help in a particular area are on the slide too, and we're not going to go into what those are. You'll get a copy of the presentation afterwards, so you can follow the links that are in there as far as that goes. But some of these things might give you some more information about talking to families, and also where to find help or information or support groups or stuff like that in your area. And
Thank
then
you,
that
Dr.
is
Cotter, for a wonderful presentation.
I'm sorry I ran over. That's what always happens.
That's okay. I'm going to unmute the lines for questions.
Okay.
Okay. Could you also go ahead and go to the very last slide, because that's going to give them the information on how to take the post-test.
Yes, this is the thing for the post-test.
The conference has been unmuted.
All right, if there's any questions, I'm happy to try to answer them as best I can.
Well, thank you for participating. If you're not at your own computer, please copy down the SurveyMonkey link and go to your computer and take the post-test. If you are at your computer, when we end the webinar, the survey will pop up and your post-test will be right there available for you.
Once you have successfully completed the post-test, you will be sent a certificate by email within the week. If you're on your own computer, a link will pop up at the end of the time. Well, hey,
are there any more questions? Thank you for participating.
Thank you very much.
Thank you.
Thank you. Please stand by.